Yes, Assalamu alaikum, everyone. Here, Dr. Asif Maqsood, the founder, president of Indian Community Awareness Program. Along with, I have Jacoline Sommer. She is our chief coordinator from the College of Nursing. She is a senior instructor, and she is today, having the responsibility for the main coordinator, the main moderator of this program. Thank you, Ma'am Jacqueline. Please, may I have the details?
Yes, today session is been based on the topic is whole person care, and this is going to be, the audience are going to be mixed doctors and nurses. The concept of whole person care will be explained, and that how patient is being looked after, including not only the disease but the other aspect of it. We do have couple of speakers, and the other speakers, there are few speakers from United Kingdom, and we have speakers from Rawalpindi, Islamabad and Karachi. So as soon as they'll be speaking, I'll be introducing them individually, so everybody would be knowing. We do have Dr. Ahmed Manzoor also, Dr. Manzoor Ahmed, who's the president of Pakistan Academy of Family Physician. Very shortly, our worthy Vice Chancellor, Professor Muhammad Umer is going to join us. He's better now, but as soon as he'll join, we will introduce him further. We do have Dr. Shazia, Deputy Director of Department of Medical Education. So these are some worthy speakers and the invitees. We do have Dr. Bushra Khar also. So I give over to Dr. Asif to start with Dr. Andy, who would briefly talk about the questions will be shared by Dr. Asif on the screen and by word also. So may I give over to Dr. Asif?
Yes, thank you so much, ma'am. Today, the purpose of our program is mainly how a physician and a clinician or a healthcare provider go through his clinical setup and his practice. And while when we are sitting in the primary and secondary healthcare service delivery services, or whether in the tertiary healthcare, so there is the whole person care importance, where it comes along with, and how we treat a patient. So in this program, we will, focus mainly that what is the importance of the whole person care. So I welcome here Dr. Andy. He's, the prime tutor and the family medicine doctor in United Kingdom. Thank you, Mr. Andy, for joining us today.
Thank you. Thank you very much, Dr. Asif. I hope you can all hear me. I'm just going to share my screen, I hope. I hope you can all see that.
Yes.
Good. So thank you for inviting Dr. Janet and I to share with you today on behalf of Prime. Prime seeks to support healthcare professionals to practice and teach sound scientific knowledge, clinical skills, while considering the effects of illness on the whole person, the body, mind, and spirit. And to with that provide care with integrity and generous compassion. So I've been asked to share with you what is whole person care and why is it important. I want to take you on a whistle-stop journey through the historical world of being a doctor. I will try to explain why 21st century medicine seems to focus more on treating things than people. And finally, before handing over to Dr. Janet, she and I will conduct a role play of a consultation, highlighting the importance of doctors' communication skills. "2,000 years ago, it was a common held viewpoint that illness can strike anyone at any time for any reason. it can come as a punishment from the gods. Maybe you hadn't made enough sacrifices, or had trodden on the wrong bit of ground, or done something wrong. Or maybe the gods were just having a bad day. This concept still persists in the times of Jesus. People asked him, "Who sinned, this man or his parents?" Jesus replied, "Neither." People asked, "Neither," he said. "Sickness happens because we are flesh and blood." It's still here today, even in the 21st century UK, when I became unwell with ischemic heart disease at a young age. People said, "It isn't right. It's happening to a good person like you." However, as physicians, we know it's certainly true that some diseases occur more frequently when people indulge in practices widely prohibited, not only in the Christian morality, but also that of other religions. So this slide, this slide shows some of the perceptions in the first millennium. So it became a bit of an eclectic mix of spiritual and physical factors. You can see damp, foul air as being a cause of ill health, or curses and spells. Some of the interventions were poultices and leeches and potions. Maybe this is poor science and doubtful theology, but actually what it does show, it recognizes the essential makeup of a human being as being more than the physical body, but being body, mind, and spirit. In the 8th to the 13th century, in the Islamic world, they played a very important role in the development of medicine in both discoveries, such as separating smallpox from measles by careful observation, and in the cataloguing, synthesizing, and translating the knowledge of practice from the Greek, Roman, and Indian civilizations. Without these translations, these would have been lost to the physicians in Europe. This slide shows a fresco in a wall of a hospital built in 1450, the Ospedale di Santa Maria di Scala in Siena in Italy. It was built to serve the poor, beggars, orphans, and pilgrims. I want you to look with me at the medical care being received. I want to draw your attention to the physician, the surgeon coming in to look after the man's cut leg. On the left, there are two physicians examining urine. Maybe it's the urine of the poor patient being looked after by the nurse, being laid down here. Maybe he is dying. Look at the facial expressions on the carers. Here we have the attendant washing the man's feet, showing that he is caring for every part of the body. Notice he's at gaze level with the traumatized patient. And finally, this man behind the patient offering a cape to cover his naked body. Why is he doing this? Is it to respect his dignity? What does his body language say to you? So this is an example of body, mind, and spirit. The Quran and the Bible recognize that human beings are more than physical. We have a spiritual component. The mind is at the interface between these two. It provides the means by which we can make sense of higher things and communicate in relationships. It binds us into one being, not the dualist concept of a separate nature of body and spirit, the one being the domain of the doctor, the other the domain of the priest or imam. It shows that we are inseparably mixed of the body, mind, and spirit. This is represented here, that we are integrally mixed together in the living human being. It becomes impossible to separate where one end starts and the other begins. We're going to fast forward to the 18th century, in the European Age of Enlightenment. This is still reflected in the arts versus science divide in much secondary education. I suspect this is true in Pakistan also, having had the British education system brought in the colonial era. On the left, you see that religion, literature, art, politics, all these things which divided could not be agreed upon. And yet science could produce things that were measurable. And the philosophy was that if science ruled, mankind would advance and wars cease. So medicine joined science, leaving behind it humanity. Not only was humanity left behind, but also most of communication and the world of values and the things which determine the direction we take in life. This next slide highlights certain consequences of this major split in the 18th century. At the top, you can see that medicine became organ-centered and it increasingly became subspecialized. On the left, it highlights that generalism was devalued and that students were selected primarily for their scientific ability, whereas communication skills were valued as being less important. So coming to today, medical training has concentrated on the science and tended to leave the soul behind. For most of us, our first encounter with a patient is in the dissection room when we meet the dead. In our training, we peel off the skin on the face and we learn about the nerves, the trigeminal nerve, and all the important structures. We so often forget to put the skin back on and look for the nervous flicker around the lips, the apprehension of a worried patient in their eyes. What do you think this patient wants to say to you? Help me? I can't believe this is happening. I'm frightened. All these are mediated through vital structures, important nerves, and blood vessels, but I suspect she is wanting to connect, to communicate, and to be understood as a whole person. This quote comes from a professor of psychiatry in London. Medical training seems to focus on how to deal with things, a liver, an MRI scan, rather than how to deal with people, such as patients and colleagues. And he goes on to say, it may be that this makes us ill-equipped as doctors to deal with our jobs and can even lead to subsequent stress and complaints. This slide talks about the World Health Organization's view. I'll let you read it, but please note that there is a recognition that once again the value of faith, hope, and compassion are noted as being important in the healing process. So We have seen that patients are not just biophysical collection of organs, but they have a social and a spiritual part. The same's true for us as doctors and nurses. We're trained to use the biophysical aspect of themselves to diagnose the problems with our patients. We use our hands to palpate. We use our eyes to look at x-rays and our left side of our brains to make differential diagnoses. But we're told not to use our own psycho-spiritual component to involve our personal feelings in work. This is called professional distance. It's a consequence of the great divide we saw earlier between science and humanities. It's dualism and leads to only treating half the patient. Whole person medicine seeks the following: that we can bring doctor and patient together so that we can use all parts of our attributes and training. We can wrap ourselves around so we can impact our patient care as human beings, heart to heart, treating the whole person, body, mind, and spirit. We're coming to the close, you'll be glad to hear. This slide is a model. I know doctors like structures. And what it is the Winnie model, which Dr. Janet will tell you more about in a minute. It is a coming together of experts. A clinician who's an expert in disease, but also the patient who is an expert in the world of their illness. The aim is to bring the two frameworks together so we have a joint beneficial outcome. So I want to introduce you to the patient we're about to meet. He's a 48-year-old man. He has chest pain on exertion, radiating to the left arm. He has a history of hypertension. He's defaulted from several follow-up appointments investigating this problem he has. Sadly, he was admitted with worsening chest pains. So many of us will be familiar with his the pathology behind his presumed problem of ischemic heart disease. You may be wanting to know what investigations he's had. Has he had a treadmill test, an angiogram? Have we started him on medications, beta blockers, ACE inhibitors? Have we modified his risk factors to avoid the bottom left picture of a near complete thrombosis, or even the right, which is a complete thrombosis? But let us not forget that this man has a heart and it belongs in a patient. Let's call him Mr. Khan. When he's told he has heart disease, do you think he's going to ask us, what stage of arteriosclerosis do I have? What chance of there being a plaque rupture? No, much more likely to say, am I going to die? So we're now going to move to the role play. I'm going to stop sharing my screen.
Yes, Dr. Andy, you have finished?
I need to have Dr. Janet with me at the same time, please.
Okay.
Right, we're now going to role play communication. I am Dr. Khan, and this is Dr. Janet. I'm not Dr. Khan, I'm Mr. Khan, sorry. Hello, Doctor.
Hello, Mr. Khan. So you're going home now today after your operation. Is that right?
Thank you, Doctor. Thank you.
Yes. Okay. I hope you know that what has happened is because you did not have follow-up properly, that you developed some raised blood pressure and then some chest pain, and we you had quite a serious heart attack. It affected the left descending artery of the heart, and it had 2 blockages in it. One of them was complete, one was partial. So we just put in 2 stents, all right? So this has helped your heart to function a lot better. So for this to be able to continue, you need to take these medicines. I have a prescription here that I'm going to give you, and on it is a list of medicines which you must take for the rest of your life. Mr. Khan, if you don't take these medicines, then I'm afraid that you are probably going to have another heart attack, and you may not survive that one.
But Doctor,
right, Mr. Khan, I'm very busy. I have to go along to my clinic now. Many patients waiting. I will see you back there in 6 weeks. So meantime, Mr. Khan, will you please take these medicines? Here is the list. Okay, thank you. Goodbye.
Thank you, Doctor. Okay, I'm going to hand over to Dr. Janet, and she's going to talk to us about how we can implement whole person medicines in our practice. Thank you.
Yes, ma'am. Jacoline, please continue.
May I introduce Dr. Janet, who is also from Prime Partnership in Medical Education from UK. And this is our honor to have Dr. Janet with us again. She has been to Pakistan to talk about Prime and to talk about whole person care with the medical students and nurses back in Rawalpindi Medical University. I can see Dr. Umer, Professor and Vice Chancellor with us. Before we give you little chance, may I have Dr. Professor Umer to be a part of it? We are honored to have him on the screen, and just to let you know, Dr. Umer, Professor, our Vice Chancellor of Rawalpindi Medical University and Allied Hospitals, has been little sick and now he's much better. Thank you so much for giving such an encouragement to be a part of this very informative session online. Thank you, sir, and I give over to you to speak about something on this session of today. And once again, God bless you. Thank you so much, having so much encourage and feeling better. We are feeling better also to see you. So
yes, ma'am Jacoline, really we are feeling encouraging and more motivating while sir is with us, and he's really source of motivation and inspiration for all of us. We all pray for your good health, for your quick recovery, and sir, get well soon, inshallah. You'll be fine.
In addition, Dr. Janet, you have happened to meet our Vice Chancellor. So thank you so much. I would like, sir, if you can speak something on this session about a whole person care in Pakistani context, and he's our keynote speaker as well. So may I hand over the session to you, sir?
सर
आपकी आवाज नहीं आ रही.
So can you rejoin? Yes.
Sorry for that interruption. I guess mic is not been on.
He's going to rejoin. Yeah, he's going to rejoin.
Dr. Janet, sorry, because Dr. Sir is not feeling well. So we thought we just add him for a while and then we can come back to the session.
Yes, sir.
Is it okay? You can hear me?
Yeah, we can hear you, sir. So we can hear you.
Bismillah ar-Rahman ar-Rahim. So thank you very much for the invitation. I really feel honored and humbled to be the part of this program, and particularly the whole person care. I think although I'm COVID positive and alhamdulillah I'm improving, so this is the best time to understand how do you feel between treating and being treated as a patient and being cared as a whole person. So I think this webinar is right in the time, at least for me, to understand this concept.
That's great.
I must appreciate the organizers and the two speakers who spared times and the impressive way they convey the message. I'm already aware of that because I met both of them many times in Pakistan. So once again, very warm welcome to the speakers on behalf of Rawalpindi Medical University and as a Vice Chancellor of the Rawalpindi Medical University. So I really appreciate your presence here. Ladies and gentlemen, I think this topic is very exciting, and not only exciting, but it is the need of the times. Over time, all over the world, and particularly in third world, in Pakistan, the concept that to treat disease or to treat as a person has a wider gap. I think all educators, trainers, teachers, institutions, universities must understand the importance of that. It is not treating only the COVID in a person who is a 65-year-old like me. I have a mind. I'm stressed. I'm worried. I know the outcomes, the dangerous outcome being a doctors. If being not doctors, I've seen the patient in my families. So who is going to address that? Is it simple antivirals? It is simple some fluids, oxygen, and then gadget rounds. I'm sure this is not going to improve the outcomes. The modern science has repeatedly proved that the outcomes not only depends upon the severity of disease, we all agree, not only the evidence-based medicine practices and good clinical practices, but on the immunity, about the spirit, about the mind, how it is thinking. I just quote one example. What is going wrong with the patient who are depressed or who are anxious? They do not have a advanced physical disease, but their outcomes are different. Their quality life is impaired. There is the evidence-based practices that if you are depressed, if you are not motivated regarding your disease treatment, compliance, better outcomes, the drugs are not that effective. And that we have seen in the pandemic of COVID also, that the patients who are very motivated, who are very looked after, very good communication with their relatives, they have better outcomes. So I've not take the long times. I think this is a fact. I nothing have to say new in this, that the patient care should not be taken as treating diseases or symptom. This is the whole person care. And I rightly appreciate that it is said whole person care, not the patient care, because the person is a human being and human being is a complex thing. So I think once again, I appreciate the prime. My heartfelt appreciation to the speakers, the excellent speaker, and the way they deliver is incredible. And also Dr. Asif, Jacoline, and rest of the member of the team to highlighting this issue. I think this motivational, this sort of lecture must be at the university levels. And next time, inshallah, as soon as the things are better, we will induct as a part of curriculum. So my request would be, and we will do in our university, that this subject, the whole person care, should be the part of the curriculum. This should be taught at the undergraduate level and stressed during the training and even in the exam. So we produce the perfect physicians. Not only the pharmacists are well-trained doctors, best human physicians to take the whole person care. I thank you once again. I have taken a long time, but I think this was important, and particularly this point of time. Once again, thank you very much, and I best for this seminar also. Thank you very much indeed.
Thank you so much, sir. Thank you so much. We're really humbled and lots of prayer for your health and your presence. Your valuable remarks are highly have worth in our life and a way forward to the improving the quality of healthcare. Thank you so much once again, sir.
Take care of yourself, sir. May I have Dr. Janet now?
Yes.
Thank you so much, Dr. Janet, for waiting. So we have Dr. Janet from UK, and she is a trainer from Prime, and she is also a doctor of family medicine from UK, working under the umbrella of Prime. So in continuation with Dr. Andy's session, may I give the session to Dr. Janet and Dr. Asif to help to get the screen on the...
Sorry. Dr. Janet, you have to go to the screen share while you just click on this option, and there's another window open, and you have to click on the screen share of the whole screen. And then in the middle of the box, you will just click on this main page, and there's a bottom word share. It will be highlight, and that will give your presentation to a share to the audience.
Can you see this or not?
Yes, you're here.
Can you see this, everybody?
Yes.
Yes.
Okay, right, okay. First of all, I want to say thank you very much to Professor Umer for his very encouraging comments about whole person care. Dr. Andy and myself are very grateful to him for what he has said, and we do join in wishing him a very speedy and full recovery from the COVID virus. So to continue from what Dr. Andy was sharing before, we want to see how we can apply this whole person care into our medical practice. He mentioned before about what's called the Winnie Model. So that you can see from the disease illness model, we have the disease framework, we have the doctor's traditional agenda, which doctors are used to working on, trying to find out the patient's symptoms, signs, doing appropriate investigations to find out the underlying pathology so that they can make a correct differential diagnosis. But the patient's agenda is often what we forget about as doctors and nurses. But we have to think about the patient's illness framework. The patient is an expert in their illness, whilst the doctor is an expert in the disease. The patient has some ideas, concerns, expectations, feelings, thoughts, effects, and he or she is the only one who is understanding the experience of illness. Professor Umer said that he at the moment is experiencing COVID, so only he knows what it is like. The patient is presenting the problem, the doctor is gathering the information. So from these two frameworks, we have to try and integrate them together for the best treatment of the patient. And this is something called shared decision making. I want to explain to you how this works through something called the iceberg model. What do we all know about icebergs? We know that we can only see about 10% of an iceberg above the surface of the water. So as the boat is approaching, it has to remember that 90% of the iceberg is below the surface. If it doesn't remember that, then there is a wreck and lives are lost. In the same way, considering a patient who is coming along with just their symptoms, we have to realize that there is a lot more than just the symptoms causing his problems. Mr. Said might come with a headache, and we need to find out a lot more about it just before giving the paracetamol. The doctor who tries to find out just treats the symptoms without finding the cause will find himself in trouble, and just as with the famous ship, the Titanic, lives will be lost. So we need to remember that the symptoms are caused by pathology. Our medical training, reminds us that we have to do some investigations, examination to find out exactly what is going on. This is the diagnostic therapeutic access, which we saw on the left-hand side of that previous slide. But there is another layer of ice beneath the surface and underlying the symptoms presented. The patient doesn't just develop a symptom and immediately present at the doctor's clinic, at least not usually. He or she has usually spent hours, days, or even weeks wondering whether to go and attend the doctor, wondering whether it is something serious enough to seek help. They will have developed some ideas about what is going on. They might have asked their friends or family if they've got any ideas as to what might be the cause of the headache or other symptom. They might even have searched the internet. Some of the advice given may be correct and some incorrect, but the ideas about the cause and its seriousness will have developed, and it is these that bring him or her to you. Often the patient is afraid to tell you these ideas because they are thinking they've got serious consequences, or because they think the doctor will think them foolish and humiliate them and say to them, that's a silly idea. We are all afraid of humiliation. But if we don't deal with the patient's ideas, we will have what is called a dysfunctional consultation. It will not be an effective one. Even if the ideas are far from the mark, even if they are not what is true, if we don't deal with them correctly, the patient will leave still wondering if the doctor's missed something or that the doctor doesn't care about getting it right. So how do you find out what these ideas are? Well, you have to ask the patient some questions. We can say, what do you think might be the cause of this headache? What did you think was going on? And then we might find out that perhaps Mr. Said was thinking that his headache was due to a brain tumour because his neighbour up the road has...
Excuse me, ma'am, Janet.
Yes?
Actually, we are having a problem that your screen is not moving. Your slide is hold on the first one. So
Okay.
I request you to play the slides.
Sorry?
Yes. Your slides are not moving. Your slides are on the hold on the first slide. So
Well,
we
I can see them moving all the time. So I'm not sure what's happening. They're moving for me.
Can you please do it screen share for one more time?
Okay.
May I? Sorry for the interruption. I actually
Sorry about this. Okay, let me try again. Can you see them now?
yes. May I request to move the slide, please?
The back one. Did you see this one?
I'm just read the letter. See how can we can apply the whole person here. Can you move forward to the next slide? Your slideshow is on the right bottom, where you have the screen boxes. There's slides, and in the bottom you just see there's icon for the slideshow.
No, at the moment it just says that I'm sharing a window. That's all. I'll have to stop sharing again. I don't think it's working very well. Do you want to share the presentation then, and I'll tell you when the next slide is coming on? Do you want to share my presentation? Do you want to do it or not?
If you do it, that will be better for a better understanding. But I'm yes, ma'am, Jacoline. Please suggest something.
Do you have a control over moving the slides, Dr. Asif?
Yes.
Dr. Asif?
If I have the presentation, then I can have.
Okay, you have to bring up the presentation, Dr. Asif, I think, that I sent you.
Okay, Dr. Janet, he's saying that if you can send him.
Okay, this is your presentation? Okay.
has
No,
to-
I take this. Okay.
Make
Wait.
a desktop presentation.
Just give me 1 minute, ma'am.
It has to be on your desktop, Dr.
Yes,
Asif.
ma'am.
Audience,
I'm just moving it.
We just got some internet connection and all. So bear with us just a second.
So it's a technical problem, not an internet one. I'm afraid.
Now you can see the presentation?
Yes, I can see that. Yes. Okay.
Okay. You can see it moving?
Yes, we can.
Okay. So, ma'am, continue from the
Please
slide.
with the
May I have the slide number, please?
I'll have to go backwards then. Go down a bit more. So keep going down. I think we haven't got time for me to go right back to the beginning. I'm sorry. Okay. Keep going down. Can you go onwards, please? Dr. Asif, can you press on? Dr. Asif, you've frozen.
I'm calling him.
Yes, okay.
Yes, ma'am, Jacoline?
You froze. You just stopped at the second.
Yeah, actually, so many people are, coming into the studio. So that was the, issue. So
I'm
I
sorry,
have to.
I have communicated, Dr. Asif. Sorry for that.
Yeah. Actually, I have each time the person's load, increases, so I have to take them out of the studio, and then it's okay. So I'm sharing the screen. Yeah, Ma'am Jacoline is fine.
Yes.
Okay. So it's moving.
Yes, carry on down now. Keep going down, please.
Ma'am Jacoline.
Yes, Dr. Asif.
Can you hear me, Dr. Asif?
I can hear you, but Dr. Asif, I don't know. Dr. Asif, are you there?
Yes.
Please keep going down. That's right. Go down some more.
Yes, I can hear you.
Right.
Yes, I can hear. Please, ma'am.
Please go to the next
Yes,
slide.
I'm here.
Next slide. Next slide.
Dr. Asif, next slide.
Okay.
Is it this one?
And the next one. And the next one. Okay, and the next one. Right, this is where I got up to. Can you hear me now, Dr. Asif?
Yes, ma'am. Yes, ma'am. We can hear you.
So I will tell you when I want you to go to the next slide. All right?
Yes, ma'am.
Okay. So I'm sorry about that, everybody. It's just a technical problem. I was able to see my slides, but you couldn't. I'm sorry. So how can we find out about the patient's ideas? We can ask them, what do you think might be the cause of it? What do you think was going on? And we might find out that, as I said, that Mr. Said thought that his headache was due to a brain tumor because his neighbours up the road has developed a brain tumor, and his brain tumor started when he had a headache. Okay, next slide, please. And if the patient expresses their ideas, then we find out what's called their concerns, the things that have really brought them to see you. And usually these become fairly obvious when we know the ideas. Excuse me. But again, we need to make sure that we know them. The concerns might be a real clue to the diagnosis. There was a very famous Canadian doctor called William Osler in the 19th century. He is called the father of modern medicine. And he said what you need to do is listen to your patient. They will tell you the diagnosis. All right, next slide, please. So to find out the patient's concerns, we need to ask them questions like this. What were you worried about? Is there anything you thought this might be? What do you fear most might be causing your symptoms? In your worst nightmares, and Mr. Said might well be having nightmares about a possible brain tumour, what do you think is causing your symptoms? And these ideas and concerns will lead to the patient having some expectations. Next slide, please. He will want to know what you're going to do about it. The expectation may just be, if it was a simple headache due to some tension, for some paracetamol or prescription. But he may need more than that. He might need some reassurance that it isn't what they fear. And unless we meet this expectation and explain the outcome, being maybe a different outcome, being a better option, which has been understood and agreed by the patient, then the patient will be leaving dissatisfied, anxious, or angry and not wanting to come back to see you again. So how do we find out what the expectations are? Next slide, please. We can ask, is there anything you were hoping that we could do for you today? What were you hoping from today's consultation? Next slide, please. So, to go back to what we saw before, we have the two agendas. We have the doctor's agenda on the left and the patient's agenda on the right. And our skills as doctors and nurses is to try and bring the two together, both during the consultation and before the end. Next slide, please. So we're going to go back now for a few minutes to Mr. Khan, the 48-year-old man, if you remember, with chest pain, who came into the hospital and ended up having a heart attack. Now he has defaulted from follow-up at the hospital because it's a long way from where he lives, many miles. He doesn't easily get there. And instead, he decides to visit his family doctor at his 6-week checkup. Next slide, please. Here is Mr. Khan. Next slide. And if you remember, he has a wife who's recently had twins. All right. Next slide. So Dr. Andy and myself are going to do a different role play now. We hope that you will see how we try to bring in some of the teaching that I have just done. All right, so we're going to stop the slideshow for a minute, Dr. Asif, and do a role play, Dr. Andy and myself, and then we will need to go back to the slides, please, from where we left off. All right, thank you. Right, good morning, Doctor. Good morning, Mr. Khan.
Morning, Doctor.
Okay, haven't seen you for a while. I think I sent you into hospital with some bad chest pain, if I remember, a few weeks ago. Can you tell me what happened there?
Thank you. Oh, Doctor, I was so poorly, and they did all these things to me and gave me all these tablets, and I feel better, but I'm worried, and I can't take the tablets. I can't afford to buy them, Doctor. I've got no money to do that, and I'm really, really worried.
Okay, so you're worried about your tablets because you can't afford them. You're looking very concerned today. Well, are there any other worries that we need to think about?
Well, Doctor, he said that if I didn't take them, I would die.
Right. Okay.
And I just can't afford it, Doctor. I've got no money.
Okay. And why have you got no money at the moment?
Well, I can't work, and I can't sell things in my shop because many people, since I've been away from work, are buying ready-made suits, and they're going to other tailors, and so my money is going down, and I'm really worried. Doctor, I'm so ashamed.
Right, this must be really difficult for you. Right, and your wife too, how is she coping with it?
Oh, well, that's the problem, Doctor. I can't provide for her and for my twins. I don't think I'm going to be able to see them grow up and to be married and oh, Doctor, it's awful. I don't know what to do. If only I could get these tablets, I'm sure I would be better.
Yes, that is quite right in that the consultant would have told you that you need to take these tablets to try and keep your heart in a healthier condition. But
I don't know what to do.
Is there anybody else in your family who could help you? What about your brother? I remember that last year when he had an accident. He's a builder, isn't he? Is your brother a builder?
Yes, Doctor. And his brother is a pharmacist.
Right. Okay.
Maybe he could help me.
I think his son's a pharmacist, isn't he? Yes. He did very well at school and was able to train to become a pharm. He may well be able to help you. But your brother, whom you helped out before, he may well be able to support you through this difficult time. Since
he might. Thank you, Doctor. I will go and ask him. Thank you. Oh, I'm better for talking to you. Thank you so much.
Okay, so come back and see me in a week or two to let me know how you're getting on with taking the tablets. We need to check that they're okay for you.
Thank you, Doctor. Okay, I'll see you then.
Okay, thank you.
Bye-bye.
Bye-bye. Okay, so we can see how dealing with the patient's concerns was very important there. Dr. Asif, can we go back, please, to the end of the PowerPoint presentation? Okay, go on to the next slide. Can we do the next slide, please? Okay, so we see that the whole person medicine involves the social context of the patient's ideas, concerns and expectations may all reflect their upbringing and current medical and also current social and religious background and their education. If Mr. Khan was a well-educated headmaster, then that would have been all different than if he'd been a poorly educated village man. Next slide. Before I just say this slide, I want to say that I know that many of you work in very busy outpatient clinics, and you might be thinking, how can we do this in our busy outpatient clinics? What Dr. Andy and I have shared has been established in the UK for many years, and it is taught to all the undergraduate medical students. But we recognise that it may be difficult to do this in your brief outpatient appointments because we have appointments that last 10 to 15 minutes in the UK. But I just want to encourage you to see if perhaps you can try and incorporate some of this whole person medicine teaching into some of your consultations with some of your patients, because you will find out that it will help to give some benefits as are listed here. We have found out, and there are references at the bottom here which we can send on to people if they would like them, that do show that there are some important health quality outcomes of whole person medicine. It reduces the mortality, it improves the compliance and well-being, it improves the job satisfaction and staff retention, and it leads to more cost-effective healthcare system delivery. Next slide, please. So these are some of the references which back up what we have been saying. Okay, next slide. I think that might be the last slide. Yes, it is. So I just want to say that I hope that what we have shared with you this morning, and which I'm sure your next two speakers are very much aware of, that you will be able to try and incorporate some of this into your care as doctors and nurses. Thank you very much for allowing Dr. Andy and myself to be part of this very good whole person medicine seminar this morning. Thank you.
Thank you very much, Dr. Janet, for such a good descriptive information about whole person care. And that was all about the UK perspective and how it is being implemented throughout the different part of the world. So thank you once again, and I'm sure the knowledge and the comprehension. Yes, Dr. Asif, I'm not clear.
Yes, thank you.
Okay,
Yeah,
so
thank you
Dr.
so much,
Andy
ma'am.
and Dr. Janet,
Dr.
thank you so
Janet,
much.
it was really very concrete and comprehensive talk to let a common person, or if we talk about the common person and the clinicians have to understand these all concepts in Pakistan. We're also
May
having some questions we will ask you in the end.
Yes, okay.
Okay. Now, may I have Dr. Saima? Dr. Saima Pervaiz Iqbal is a professor, family medicine from Shifa College of Medicine, Islamabad, and she has been a very instrument for generating the information about whole person care into her own practice and with other friends of her to talk about the whole person. And she'd be talking about the Pakistani context, that how this has been feasible. And we have Dr. Fauzia who would take over from Dr. Saima to talk about the challenges. So some of the Pakistani perspective, and she is working from Islamabad, and definitely she is conducting so many workshops to talk about the whole person care. So may I give over to Dr. Saima Iqbal. Welcome to the studio, and I hope we will have a good information from you.
Welcome, ma'am.
All right. Thank you, Jacoline. Thank you, Dr. Asif. I've just shared my window. Can you people see it?
Just 1 minute. Yes, ma'am, please.
Okay. So I hope this is visible. The whole person care in context of Pakistan. Asif, is my slide visible?
Yes,
Yes,
ma'am.
yes, yes.
All right. All right. Thank you so much. Okay. So I won't take extra time. I just take over from how Dr. Andy and Dr. Janet was there. They talked about the concept of whole person care, what it entails. And now I'm going to tell you what whole person care would look like in the Pakistani context. If you could see this slide, just a few facts about Pakistan. We are a third world developing country. We are one of the fifth most populous areas in the world, with a population of more than 212 million. We have an annual growth rate of 2%. Most of our population are the young population, which are in their productive years, between the ages of 15 and 64. So at least 65% of our population belongs to this age bracket. We are predominantly Muslim, and we are generally a family-centric society. Now, Pakistan is one of the signatories to the WHO's Sustainable Development Goals of 2030. And some of the highlights of these SDGs are that we have to promote universal health coverage for all. We as a population have to address health emergencies within our country and to promote a healthier population. And the best way to deliver that sustainable development goal is through the family medicine approach. And why do I say so? I say so because family medicine is holistic. We are patient-centered, and we are not only looking at health promotion, disease prevention, but also looking at curative care. Now, in Pakistan, how many of us are true family physicians? So these is according to the latest data that was available from the PMC website. So we have about 200,000 plus registered medical practitioners within Pakistan. They have been registered with the Pakistan Medical Commission. Among them, only 48,000 are specialists who are registered. Most of the patients in Pakistan, when they want to go for healthcare, they seek it from their local GP. So more than 70% of our patients will seek care from their local general practitioners. And who are these local GPs? These are these registered medical practitioners, and most of them are untrained, who have joined practice after undergraduate medical training. So unfortunately, we do not have the specialized family physicians uh, to become a part of this workforce. So Pakistan needs more than 60,000 new family physicians as specialists for us to meet the demand of universal health coverage. So currently, the situation of family medicine in Pakistan is such that most medical colleges, and we have about more than 110, most of them do not have departments of family medicine. I can only give you a few on my fingertips, which do have established family medicine departments. But the situation is not so grim anymore because recently the government of Pakistan is showing an interest to develop family medicine in the undergraduate and at the postgraduate level. And once we have this family medicine department established and we have our undergraduate students being exposed to the concept of family medicine, then they will be hearing terms like the biopsychosocial model of healthcare. They'll be hearing terms like patient-centeredness. They'll be hearing terms like holistic approach. And once that becomes a norm in our medical students, we will have more people geared towards family medicine, and these people will then be able to deliver the whole person cared concept. So once we have enough trained family physicians, they will be able to deliver whole person care. But in Pakistan, I would say it would be more apt to call it whole family care, because as I said in the beginning, we are a family-centric society. So, it's not only the person that we have to focus on, we have to focus on that person living within the family. And the focus for these family physicians will be to provide care for not only the adults, but the neonates, the children, the adolescents, adult men, women, pregnant women, elderly. So as trained family physicians, what do we need to understand? So once we have a pool of trained family physicians who are geared towards the concept of whole person care, uh, Pakistani physicians need to understand that we have certain family dynamics. You need to understand that we live in hierarchical relationships. You need to understand how these relationships work within the family. So, a Pakistani physician should be able to understand what are the intricacies of a daughter-in-law taking care of a mother-in-law, or what are the intricacies of a daughter taking care of a parent or a son taking care of a parent. You need to recognize what is important to families as a whole and at the individual level. So you need to understand that in Pakistan, religion is very important to most of us. Spirituality is an important concept. Family values, respect for elders, care for compassion for the elderly, care for the young generation. So, family physicians need to develop an open mind and good communication skills. And we need to now move away from a more paternalistic or patronizing approach that we have been used to up till now. Because, as I said, we are a hierarchical society. Doctors are placed on a pedestal. Patients will agree to whatever the doctor has to say, so much so that doctors then develop a sense of superiority. I maybe now that's not the right word to use. It's more that they, because they have a paternalistic approach, they feel that they are here as an advisory role rather than more of a facilitatory role. So trained family physicians also need to focus on patient-centeredness. As I said, while focusing on the family as a whole, you need to give vulnerable persons a chance to represent themselves as well. So, within a family structure, it is the elderly, the adult, or the male breadwinner who gets a lot of say. but that does not mean you neglect the people who do not get a chance to represent themselves. So this could be the daughter-in-law who is unable to voice her opinions. It may be the adolescent child who is considered too young or too brash. People don't listen or acknowledge them as important members of the family. You need to look at the health belief model of the family members as well. And generally, what I tell my students is that do not challenge the health belief model of families, because the health belief model, of whatever sort it is, it's quite instilled in our infrastructure. So don't challenge it right away. Try to work within that health belief model, because that will make patient compliance much better. Develop good listening skills. We got a good role play from Dr. Andy and Dr. Janet, in which the doctor was speaking, and it was not getting through to the patient. So one of the essentials for us is, as Pakistani physicians, that we need to listen to our patients more often. There was a question in the chat box regarding the flourishing of quacks, and quacks flourish because they listen good. And so now doctors need to develop that patience and that skill. Encourage problem solving in your patients, because, as a society, when patients present to the doctor, they come to you for you to solve their problems. And it's not possible, humanly possible, to solve our patients' problems, at least most of them. So encourage them to think for ways out. And we could see that in the second role play that Dr. Janet and Dr. Andy described, that just nudge them into the right direction and encourage them to think for themselves. So this is my final slide. So as family physicians, we need to be a bridge to reach out to all family members. Pakistani society can be quite judgmental, biased, and emotional. So, as physicians and as healthcare providers, we need to be above that. Develop a sense of patience and listening to the other person's point of view. Think about the therapeutic distance in our context, because remember, we were where as a society we give importance to family relationships. Maintaining a therapeutic distance, as in the Western world, may not be possible. So here, patients trust their family doctors to such an extent, they'll even ask you, about should we get married into a particular family? Doctor, what do you think? What is your opinion? So the therapeutic distance in our context will be slightly different. It's not an easy balance to maintain, because you need to maintain your own sanity as well. You can't be involved in your patients' problems and their family's problems as well. So I will just end here by a German theologian and philosopher, Martin Luther, who said that if anything needs to be done well, you need to pay attention to the whole person. And again, I just add here the whole person living within the Pakistani context. So that is all for now from my end.
Thank you so much, Dr. Saima Iqbal, for sharing some of the very relevant and true facts from Pakistani culture and perspective. And I'm glad that we are able to hear the description of that, how the emotional and different things need to be taken into consideration while the patients appear to the doctors. Another important challenge about sharing and utilizing the health belief model while patient appear to the family physician or to any doctor. So thank you so much, which has highlighted and the importance of utilizing those era of the site from the patient perspective. Another important thing that I really would like to mention, that the word that you have little bit changed about whole person care is not whole person, it's a family, because Pakistani or Asian people are known for family oriented rather than a person oriented. So once again, thank you so much. In continuation with your positive aspect of utilizing the importance of whole person family care. We would like to have Dr. Fauzia Akhtar. Thank you so much, Dr. Saima. So Dr. Fauzia Akhtar has joined us from Karachi, and she is assistant professor, family medicine from Jinnah Sindh Medical University, Karachi. Dr. Fauzia, I welcome you from the organizer to the studio. And
thank you
we
very much, Jacqueline. This is my pleasure to be here and talking about this important topic today in this session. I have shared my screen. Have you? Can you see my slides?
Dr. Asif? Yes.
Are my slides there? I can start.
Yes, please. You start.
Okay, yeah. Okay, so the most of the things about this whole person care is almost discussed. Andy, Janet, they told us about whole person care, and Dr. Saima very nicely discussed about our Pakistani context. That this is not just the whole person; this is the family care which we need to see. But in Pakistan, we face many challenges while delivering this whole person care, and I will be just discussing few of them, and we'll just try to just figure out some solutions to it and see how it works. So as we all know that the principle of whole person care is that the care is personalized, the care is coordinated, the care is enabling, and the patient is treated with dignity, compassion, and respect. So the challenges, when we come to the challenges, as Dr. Saima discussed, that the holistic care can be provided by a family physician, a trained family physician. And since she shared all the figures that this family medicine training is not available at our undergrad level, so most of the GPs who work in general practice, who work as a primary care physician as a first contact, they are never been trained to provide the holistic care because they are never been taught in the undergrad years how to treat a patient holistic as a whole person. And still in the postgraduate level, we treat the patient as a patient in physical, not the patient's mind or the soul. So we are treating the patient as all the physical problems are being catered, but the underlying concepts, the ideas, the concepts, the problems which patient is coming with are never been addressed here. So basically, this is the lack of training at both undergrad and at postgraduate level. Then our doctors are poor at the consultation and communication skill, and the reason is the same. The reason is they are never been trained to become a good communicator. They are only be trained to become a good doctor who are treating the physical illness of the patient. Then a teamwork approach. Until and unless we won't have a teamwork approach, whole person medicine cannot be practiced in our setting. So a doctor and nurses and other healthcare workers, they all are working in silos. And when we talk of whole person care, we are not only going to train, we are not talking about training of our MBBS or our doctors student, we are also talking about all healthcare workers, because this whole person care should be delivered by the nurses and all other healthcare workers in our system. Then there is a bit of problem with the knowledge to treat particular disease. As we say that after MBBS, our GP is there sitting in the clinic alone treating patient, and when he's never been trained to be a physician of a primary care, so when he's sitting alone there, the doctor is unable to treat many of the diseases. So because of the lack of knowledge of diseases, he or she is unable to deliver that whole person care properly. Time constraints. This is the major problem and major challenge in our society, because when we are seeing a patient, as Janet mentioned, that they have a 10 to 15 minutes consultation time for each patient. In our scenarios, especially in public sectors, when the patient is being seen, hardly a doctor gets 2 to 3 minutes to communicate with the patient. There is a long queue of patients waiting. Everyone is in a rush, and the doctor cannot give sufficient time to each and every patient. Then when there's a time constraint, the rapport building between the doctor and patient is not there. And when the rapport building is not there, most of the issues with which the patient comes in the clinic are not addressed in that clinic. Then there are few environmental and cultural challenges we face. Lack of privacy because of shortage of space. As you can see in this picture, The doctor is seeing the patient, but at one time there are many patients around. So there's no privacy. Patient cannot discuss their personal views, their personal issues, the things which they are coming in, they have in their mind, but they cannot discuss because there are many patients, many other patients and attendants around, and they cannot talk about it. When the patient comes in, they have many myths and beliefs, and to overcome them, it takes time. And already the doctor is short of time, so things are not done properly. In our culture, the main factor is opposite gender. If the patient is a female and the doctor sitting there is of the opposite sex, that is male, many of the issues which a female patient has will not be discussed with that doctor because culturally they are not comfortable sharing their personal things or some things which are related to their some gynecological issues to discuss with a male doctor. Then we have poor collaboration between healthcare systems. When we talk about family medicine, we cater patients, we can manage most of the patient in our clinics, but then we need collaboration which can be interdepartmental, or in the other institute, we need proper collaboration that the patient, if they need to be seen by other specialists or other doctors, or they need certain other things, the collaboration is not good, the referral system is not good. And then we have limited availability of sharing of understandable and culturally appropriate information material. Patient factors are very important. There is a very low level of education and health literacy in our part. As the role play done by Andy and Janet, this showed a patient who was Mr. Khan, and at the end Janet said that if this patient would have been educated, the things must be a bit changed. So most of the patient in our scenario, they have low level of education, and even they are not health literate, and they are unaware of their healthcare rights. When they're coming into the clinic, they don't know what are their rights, how they can come and things can work together. So the few solutions we can tell about are the problem. Firstly, the most important thing is we need training, and training not only at undergrad and postgrad level, but our trainers also need to get trained, because these trainers who are working as consultants are never being trained to provide whole person care. So firstly, we need to train our trainers, and then this thing can trickle down to our postgrad and undergrad trainees. Second is a doctor should be trained to involve the family and friends in decision making, because in our scenario, a patient who is sitting there with you cannot make their own decision for themselves. So the family should be communicated, and they should all come in to make a decision. Collaboration and team management is very, very important things to practice whole person care. Then there should be a sensitivity to non-medical and spiritual dimensions of care. Respect for patients' need and preferences. Their ideas and concerns should be addressed. Then there should be free flow and accessibility of information to the patient, and which requires time management, which requires more time. Then we should empower and engage people and communities in decision making. We should reorient the model of care from doctor-centered to patient-centered. The division of responsibilities between the healthcare workers should be there, and the service should be coordinated within and across all sectors. Public education and patient engagement can be done with health literacy campaigns, and there can be internal rewards and incentives and a supportive care environment within a healthcare system. And there can be the incentive can be as a healthcare provider of the clinic, the one who has provided very good care throughout that month, and that we can come to know with feedback of the patient. If we have a feedback system of a patient, we can get feedback from the patient, and then we can incentivize our staff and our staff members. Now, the integrated medicine, this is the potential solution of healthcare crisis, and this can only be delivered in a family medicine center or a primary healthcare center. And it informs and involves patients' decision-making, self-management. It coordinates and integrates medical care, It provides physical comfort and also the emotional support. It understands patients' concept of illness and their cultural beliefs. It applies to principles of prevention, health promotion, and prioritize self-care, and it acts as bridging conventional and alternative medical system. And in the last, I would like to say that success comes when people act together, and failure tends to happen alone. Thank you.
Thank you so much, Dr. Fauzia. By the time Dr. Asif join us, and especially the point that you have spoken about the integration of the team while the patient is not necessarily in the community setup, but having them in the hospital setting up setup also. So
Yeah.
once again, thank you so much, highlighting a very relevant challenges that is being faced by the family physician per se. But in addition to your speech, I would also like to add, because you have mentioned and other doctors have also mentioned the important role of nurses when they play a part in providing the care. And just to add that for the last many years, we are struggling as an educator that how nurses can move from the medical model of teaching versus to the care model, where we use nursing model. We have been using the healthcare model. We have been using a integrated care. So yes, there is a time when evolution has to come to the nursing, because a long time ago nurses were taught by the doctors, but many years now this over has been given to the educators, where nurses can teach the nursing care and considering the whole patient care in their care also. So once again, thank you so much. Another point about there is a constant challenges faced by the family physician trainer, and I'm sure we are going to have Dr. Manzoor, who would take up some of the concerns to bring change in the curriculum and how trainers could be prepared to integrate the concept of whole person or whole family care into their ongoing care. So may I, you all can see we have Dr. Manzoor, who is a pioneer and who's president of Pakistan Academy of Family Physician, and we warmly welcome, because his presence would make a lot of logistics and legislation kind of changes in the curriculum, making sure that the concept is going to be integrated in a council level of Pakistan Medical Association and the council. So may I give the over to Dr. Manzoor Ahmed. Thank you so much for accepting our request and joining us, and we want him to let us know, because we are end to the speaker, that he has heard about the speaker from the UK perspective, from Pakistan perspective, the challenges and the description, and I hope to have some further light that how further take up would be taken in the medical profession. So may I ask Dr. Manzoor to please open the mic?
Yeah, I will do.
Assalamu alaikum. Good morning, UK, and good noon, Pakistan. I am thankful to organizer of this extraordinary seminar, Dr. Asif, Dr. Jacoline, and the other speakers. It had been a very good talk about whole person treatment. But in Pakistan, apart from whole person, it is a family, whole family management and treatment of patient. Because if in Pakistan, very few, according to Dr. Saima, he's right, she's right. Most of our family physicians, when they complete their graduation, they start practicing, and they are not fully trained to treat patients. And we have arranged since last 10 years different programs for family physicians, arranging different seminars, arranging different workshops to train our family physician for their capacity building, updating of their knowledge to treat their patient, whole person, and whole family. Because the main thing for family physician is communication skills. He must know that what to talk and listen to their patients, so that patients should feel confidence in your physician, that patient has a confidence in patient that doctor is competent and he listen to him or her, and then he treat him or her with his full capacity. So I would like to ask and request different universities and government institutions to arrange different courses for family physicians and start different seminars and other things, so that family physicians are well versed to handle their patient in a better way. Because the family physician is the backbone of any health society. First of all, the patient come to their family physician. Then family physician see the patient. He must be fully equipped with knowledge, and he should know the latest guidelines about any disease. He should see the patient as a whole person, not as a disease. We want to not only treat the disease, but we also want to treat the whole person, his socioeconomic class. We must know from which class is he or she is coming from, and we also know his family background. We also should know that what he wants to listen and what he wants to say. And in this regard, the family physician are the backbone, because once patient has a confidence in family physician, he will be satisfied about doctor and the treatment. And the main thing that what we are going to do in future is that we should train family physicians to see and examine patient as a person, as a family, as a society, so that they are much better treated. And also, we have been arranging different kinds of training programs for family physicians, and since last 10 years, there are number of family physicians which are well versed with the latest guidelines about any disease like hypertension, diabetes, and psychiatric illnesses and other problems. So this is the basic duty of a family physician, that he must has a communication skill. He must listen to the patient, and so he must be empathetic with the patient. And patient should know that doctor is taking interest in him or in her, and he is listening to him or her. Then patient will be satisfied, because when you don't listen to patient and only examine the patient and give him prescription, he will not be satisfied, because he will only be satisfied when you listen to him and talk to him what he want to listen. You do your treatment on scientific basis. You treat him on scientific basis, but you must listen to him, because in Pakistan, most patients are uneducated. They have different myths and they have different concepts. We have to listen to them and don't want to irritate them. And we will do what we want to do, but we must satisfy them. And future of Pakistan lies in training the family physician, so that they can look their patient in a better way. And if family physician is unable to treat the patient, he must refer the patient at proper time to the consultant and concerned field. And this will lessen the load on the tertiary care units and the consultants. Only those patients should be referred which the family physician cannot treat. And this is the basic duty of a family physician. He should take his patient and listen to his family and prescribe medicine which the patient can afford. And he should have also links with different leaders of the society who can support the patients in purchasing medicine. Otherwise, if you prescribe the good medicine, but patient is poor, he will be unable to purchase the medicine, and it will be difficult for him to be treated. So I think we have to take up everything in our mind, that patient socioeconomic class, patient background from which is coming, patient's family, patient's so, number of members of the family, and he also should have a good relation with his patient's family, so that family should also be satisfied with the doctor. So I think the future of Pakistan, or future of medicine, is depend upon the family physician or general practitioner. They should be well versed and well trained, so that they can well communicate with the patient as a person, as a family, so that they are satisfied and they are treated properly and according to latest guidelines. Thank you.
Really thankful, Dr. Manzoor Ahmed, for very crisp and the notes. Yes, we are facing these all, and for that reason, we are all here. We're all here to bring the quality of healthcare, not only in the healthcare delivery services and the physician level and the clinical level. And I hope with your support and your guidance, we will achieve the task that we will provide the standard of education, and we will include the whole person care in our curriculums and in our educating system. As Professor Dr. Umer said, that yes, this is the need of the time. This is the need of time where we have to decrease the burden of the patient, not economically, but also in the prescription. And when we will, see a person as a whole, and carry his, see his ailments, so then we will find out many things behind his illness. So thank you so much, Dr. Manzoor. Ma'am Jacoline,
I also want to pray for Professor Umer for his speedy and complete recovery.
Thank you so much.
He is a motivation for us. I also want to thank Jacoline and Dr. Asif, Dr. Andy, Dr. Janet, and Dr. Saima, and Dr. Fauzia for their excellent presentations.
Thank you,
sir. We will request all of the speakers to please
on
be
their cameras.
On their cameras. We have few questions, and I'm going to start. And there's another. We have contacted our member of Executive Board of Advisory, Professor of Medicine. She's a gastroenterologist, and she's another inspiration for us, Ma'am Bushra Har. She would like to join here, but I think she's a little late, busy in somewhere. But till then, we will wait for her. We will share a few questions for the speakers. So first question is with Dr. Fauzia, that does this concept could implemented in our community where quacks are more welcome than a qualified person?
Dr. Asif, for asking this question. Can you hear me?
Yes.
Yeah. Thank you, Dr. Asif. Basically, we should know why quacks are so popular in our society as compared to our trained doctors. And the reason I see is their communication skills. They are very good at communication, and they build a very good rapport with the patient. And if this is the only reason, I think we need to train our undergrad students, because as I talked about the challenges, one of the challenges was that our communication and consultation skills are poor. We don't build a very good rapport with the patient. We only talk to them about their physical ailments. We don't talk about their emotional problems or their other issues which are going around them. And quacks do that best. So we can practice this whole person medicine if we train our doctors, our physicians, our nurses to deal with all these problems. If we just teach them a good communication skills and how to build a rapport with the patient, I think our students can work much better than these quacks.
Yes,
Okay.
Dr. Asif, question.
I would like to have Dr. Andy on the same question. Yes, Dr. Andy, any of your perspective on the same question that may I repeat? Does this concept could implemented in our community, like our community in Pakistan context, where quacks are more welcome than a qualified person?
Thank you. Yes, I would agree with Dr. Fauzia that communication is crucial, and the time to build rapport. In our country, in the UK, people pay money to see a non-doctor, and often when you pay money, you feel that you're getting a better quality. How much you pay is dependent on what you expect to get back. So I think where there's a transactional relationship, it is often the relationship between the therapist, between the expert, and the person coming to seek the advice. So my answer would be, in Pakistan, I agree, communication and time to communicate is crucial. It's about building trust. People won't come back if they don't trust you, if they don't understand the reason they're being asked to do things. And that takes time and it takes trust. Just because I have an MBBS does not mean I understand what it means to the patient. And I think that's crucial. So I agree with Dr. Fauzia. It's about communication and trust.
Yes. Thank you, Dr. Andy. The second question I would like to ask from Dr. Janet and from Dr. Saima to respond on this. How a general physician, where he see 100 patients OPD, can improve in practice as your guidance. Please elaborate this.
Shall I go?
Yes, ma'am.
Saima. I recognise that this is very difficult and you cannot possibly do it perhaps for every patient, but perhaps if you can just do it for a few, you could perhaps see that there is one patient who's looking particularly worried, and perhaps if you could just say, "You're looking worried, can you tell me some of your worries?" All right, so I think to start with, just because of the pressure of work that you work under, that you may just have to start with a few patients. And perhaps give that patient a little bit more time. That is the way that I found it. I've also worked in Pakistan for 12 years, and I found it just to ask ideas, concerns and expectations of a few patients, just as the opportunity arises, and that is the way that you can start. I'm not sure what Dr. Saima would answer to that.
Okay, so if I understand the question is that in a healthcare system in which doctors are forced to examine patients and see 100 patients in one sitting, how is it possible for us to listen to each and every problem? I never said it was easy. This will always be a challenge. I think, first of all, our doctors need to recognize it is humanly impossible to give your attention to 100 patients in one 3-hour sitting. So you need to understand the doctors who are there. You cannot be a good family physician if you over exceed the number of patients you can humanly see. Our healthcare systems are burdened. We need more doctors, and we need them away from the tertiary care centers, so that and once you establish your own clinic, but you need to understand that you have to give at least, let's say, a minimum of 10 minutes to each patient. And unless you recognize that, and unless the doctors and the healthcare providers recognize that, this system, this cycle will keep on going. So, so the challenge here is not only for doctors, but also the administrators, that, you cannot humanly, it's impossible to see 100 patients at one go. We are not providing good consultation in that. So recognize this issue, and then we'll work towards solving problems.
Okay. One more question from the same speakers, like how we can improve community engagement. We have already discussing this thing. So can you briefly give some key points for the healthcare professionals, for the care providers, like how they can improve the community engagement?
Okay, so I think community engagement is best done with providing information. So one, the fact that you're holding a whole person webinar is our form of community engagement. And people who have attended this webinar will now go on and spread the information. So the information, we have to be innovative in using social media platforms, coming onto the media, using print media or social media or emails or whatever. So and you'll see that it is the younger generation who are more community savvy, who will be able to spread the message and spread the word around. So yeah, information and responsible information.
Yeah, thank you so much, ma'am. Now I would like to, we have with us Professor Dr. Bushra. She is Professor of Medicine, and she is a member of Executive Board of Advisory. I welcome ma'am Bushra. Thank you so much for your valuable time. Ma'am Bushra, can you hear us? Yes, thank you so much, ma'am. Wa alaikum salam, ma'am.
Assalamualaikum. I am Professor Bushra Khan, Professor of Medicine, Rawalpindi Medical University, and I am really thankful to the organizers of our Rawalian Community Awareness Program, who have given me opportunity to talk about this whole person care in Pakistan. I think I must appreciate Dr. Asif Maksud, who has taken a lot of pains for producing awareness in the community regarding different medical and healthcare problems. Regarding this special thing regarding the whole person care, I think while I was teaching the medical students, I always tell them that you are not treating a disease in a person, but you are treating basically a person with a disease, or you are treating a diseased person. So you have to take the person as a whole. It is not that you are just treating a disease. It is that you are treating the person, and not only the person, but his social in his social context also. You are treating him, his environmental context, his family context, and all these things have to be considered while you are treating a person. Now, in this era, when there is a super specialty era, and a lot of people, they are talking about the super specialties, and they are basically providing healthcare in super specialties. The family healthcare has become very important, especially the primary healthcare has become very important, where the patient is going to be taken as a whole person. He is not being taken as a system, a disease system, but he will be taken as a whole person who is suffering from a disease and in the context of his family. So I think this topic is very, very important in this era, that we should teach our students, our healthcare professionals, our healthcare workers, and all the people that how they can provide healthcare to the person as a whole, and context to his family and his environment. So I think it's very important, and especially in our circumstances, where we have got a lot of communicable diseases. We have infectious diseases, and which basically affect, sometimes they may affect the multi-system involvement. So it's very important that we should know and we should provide knowledge to our students regarding these things, how they can prevent the communicable diseases, how they can develop awareness among the communities regarding the communicable diseases, how they can get rid of these communicable diseases. At this point of time, I must mention the example of Chairman Mao Zedong, that while he was building up the new China, then he collected all the healthcare professionals and asked them that what is the commonest cause of the disease. And then the people told him that the infectious diseases are the commonest cause of the diseases. And he said, then how they spread? And they told it is basically it is the unhygienic and contaminated water which is responsible for many of the diseases. So he ordered in that day that all people should drink water, boiling water or warm water in China. So since that time, all people are drinking warm water in China. So this is how you can produce an impact on the diseases, and they have produced a great impact on the communicable diseases in China. So this is very important that we and our health providers and policymakers should also understand that how they can provide community preventive aspects of the diseases in the community, so we can prevent the communicable diseases, which are the most common cause of illness in our society. And I think the Rawalian community awareness program is basically it's basically will be a milestone in this regard, that they are putting a lot of effort in making the community aware of this aspect of the diseases. I again thank you, Dr. Asif Maksud, and the organizers of the Community Awareness Program and organizers of this webinar to give me the opportunity to give a few words regarding this program. Thank you very much.
Thank you so much, ma'am. It's really honor for us, and your remarks are really motivating and inspirational for us. You're all the way supporting the Rawalpindi Community Awareness Program, and we are really humble and grateful for your continued support. And inshallah, these efforts will continue under your guidance and your mentoring. No, I would like to have the end few words. Ma'am Jacoline is here. The speakers. So, Ma'am Jacoline, your final conclusive remarks upon the whole person care, and then vote of thanks to the speakers and all the participants.
Thank you so much. We had such a good discussion over the different perspective and from different perspective as far as the culture is concerned. And you all have highlighted the importance of having the whole person or whole family approach into British context, into Pakistani Asian context. So thank you so much, and I hope we all are going to take up the not the challenge, but the hope and the mission to continue with the challenges of facing and overcome and eradicate, as we have Dr. Manzoor to take up our concern, and he's ready to support to conduct different workshops. So everybody is aware. The first context is we all spoke about that everybody should be aware about the importance of it. Then though the whole perspective was focused on doctors, where doctors could play a part to the community. But in addition to that, some of you did talk about the team approach. And we have understood that not one doctor can take the burden of community as far as the disease is concerned, but nurses can also play a part where they can have a approach to spread the health education. So doctors can pay attention on scientific approach looking at the diseases, and the nurse can also sit beside him or with him, where the sharing information of health education can be taken care by the nurses also. And hope we will continue the mission to spread the news and information, because whenever we conduct a seminar or conduct a workshop, it's always a new audience. And I have been asked that what is the feedback. Obviously, initially we are in a stage to spread the news and bring the knowledge importance, and we have been increasing the number, because so far we could not train so many nurses to be a part of this workshop, because the focus is always on family physician doctors. But next time we would make sure, as people have commented, the nurses would also be taken care along. So rather than having a separate and different workshops, we all both healthcare provider can sit together and can understand the integration of concept into our own curriculum and own patient care as well. So once again, thank you so much, the speakers, Dr. Fauzia, Dr. Saima, Dr. Manzoor, Dr. Andy, and Dr. Janet, and hopefully we will be in contact. So over to Dr. Asif.
Yeah, you have done the vote of thanks and the final remarks. I would only, have to say that this program and this seminar, the webinar, is not possible without your support, especially Ma'am Jacoline, Dr. Manzoor, Dr. Janet, Dr. Andy. Throughout, you have supported a lot, and really, special thanks to Dr. Janet and Dr. Andy, that we need your thorough guidance, your support, and the further I'm taking this whole person care, as the Professor Umer said, that we will include in this curriculum, and we will have a certificate course, as Dr. Manzoor said. So I've already proposed the certificate for holistic healthcare, or a holistic model, and the whole care person. We will, inshallah, very soon, it will be submitted to the Office of Vice Chancellor. And further, Dr. Janet, Dr. Andy, and Dr. Manzoor, your special guidance, and then the team of Dr. Fauzia and Dr. Saima, and we will, proceed further to bring the quality of healthcare in Pakistan. Once again, thank you so much. Thank you so much. I'm really humbled. I'm really obliged, grateful. Thank you so much.
Nevertheless, we should thank Professor Umer.
Yes.
Beside his health, he was able to join us and gave a speech also, and because of his weaknesses, even then he joined us. So that was more encouraging. So once again, we thank you, Dr. Umer also, and Dr. Bushra also. So that is a great help, and he committed that in future he will be a initial source of our continuing making all the logistics. So once again, thanks to Professor Umer and Dr. Khar also.
Yeah, thank you so much, and we'll see, inshallah. Thank you, Ji. That's right.
Bye.